Good morning. Today, our topic of discussion is MIH, that is molar incisal hypomineralization. So, what is the definition? This is the definition given by Virgin et al. In 2001 as demarcated qualitative developmental defects of systemic origin of the enamel of one or more permanent molar with or without the affection of incisors. This is the clinical appearance of MIH. The importance of early diagnosis and management will be understood later. The previous terminologies that were used were hypomineralized permanent first molar, non-fluoride hypomineralization, cheese molars, etc. Why first permanent molars and permanent incisors are particularly affected? Because the mineralization of first permanent molars and permanent incisors occur approximately the same chronologic time. And what is the etiology of MIH? There are prenatal, perinatal, and postnatal causes. The prenatal causes include medication, smoking, illness, stress, hypocalcemia, and diabetes mellitus, that is during pregnancy. And the perinatal causes include cesarean delivery, birth complications, low birth weight babies, and postnatal etiology include childhood diseases like asthma, fever, chickenpox, measles, rubella, etc. And what is the prevalence of MIH? Globally, the prevalence of MIH is around 13.5 percentage, and in India, 10 percentage, and in northern Kerala, a prevalence of 19.8 percentage has been seen. So, what are the clinical features? First one is the teeth affected. I already told you these are the teeth which are affected. Permanent incisors and first molars. Then demarcated opacities. That is, the MIH opaque area is clearly distinguished from the surrounding sound enamel, and where the enamel is porous and soft clinically due to the presence of disorganized and weakly structure attached prisms, which favors greater microbial proliferations and foot lodgement, resulting in establishment of caries. Next is post-eruptive breakdown. The affected teeth is fragile and fractures easily due to reduced hardness and elastic modulus, and they undergo fracture soon after eruption due to masticatory force, and this results in post-eruptive enamel breakdown. And sensitivity is a main problem that is faced by these patients, and it can be either spontaneous sensitivity or sensitivity to cold and heat, and the child becomes reluctant to carry out appropriate oral hygiene measures, and they develop dental phobias, and so it is difficult to manage them clinically. And these atypical cavities will result in atypical restorations, which are extending to the buccal, palatal, uh, or labial surface of the tooth. And if the patient already comes to us with an extracted molar, extracted first permanent molar, then in such cases, you can notice the other molars and incisors show the above mentioned clinical features on examination. So, what is the differential diagnosis of MIH? First one is amelogenesis imperfecta. Here, usually the condition is a generalized involvement of all teeth. Primary and permanent dentitions will be affected, and there will be a positive family history in most of the cases. Another differential diagnosis is enamel hypoplasia. It is a quantitative defect, and here the margins of hypoplasia are mostly regular and smooth in contrast to the MIH lesions. And another condition is fluorosis, which occurs as a result of excessive fluoride absorption during tooth mineralization, Here, the defects are linear, patchy, and confluent opacities without a clear boundary, and there will be a history of residing in fluoride belt areas. Now, managing MIH. In the usual cases of dental caries, the preventive approach is very important. Educating both the child and their caregiver about MIH, its potential impact, and the importance of oral hygiene is essential. Preventive and oral hygiene measures like using fluoridated toothpaste, diet counseling, minimizing sugary and acidic foods and drinks should be advised. And professional topical fluoride applications, use of pit and fissure sealants, and remineralizing toothpaste are all good in this condition. The remineralizing therapy using CPP, ACP, and inaffix like toothpaste are favorable in this condition. And in case of restoration, you can use either glass ionomer cements or composite restorations. Temporary restorations with glass ionomer cements or resin modified glass ionomer cements are advised because it is easy and quick to handle, and they will seal the sensitive MIH teeth, and remineralization may occur because of the fluoride content. And second respiratory option is this composite restoration. Here, the affected enamel has to be removed until sound margins has to be obtained for composite bonding. So, need for LA is needed in such cases. And long-term restorations like preformed metal crowns and indirect restorations and ceramic onlays all can be given in long-term cases, long-standing cases of MIH. And in case of anterior teeth, you can try microabrasion or even anterior composite restorations. And another new introduction in this field is resin infiltration. Here, you are using hydrochloric acid instead of orthophosphoric acid for etching and aesthetic improvement, even though it varies from case to case. Increased micro hardness has been reported in all the cases. And in cases of anterior teeth in post eruptive stages, you can give full crowns or veneers are also advised. And in cases of pulpal involvement, pulp capping, pulpotomy, apexification, or root canal treatment, or even revascularization in case of young permanent tooth are also advised. And as a last resort, there in some cases you will have to extract the first permanent molars, and in such cases a comprehensive orthodontic diagnosis has to be done to decide about the extraction age of the permanent first molars. And there are some difficulties in managing these patients. First one is sensitivity, which I already explained. Second one is difficulty in obtaining anesthesia. Because of the extensive porosity and surface irregularities, external stimuli like thermal or acidic can penetrate deeply and more into the pulp, and pulp becomes hyperemic and chronically inflamed and hence difficult to anesthetize. So for this, you can give supplementary techniques like intraligamentory injections. Then 4% articaine has been found to be advantageous in MIH cases because it has more bony penetrations. And also you can use newer modalities like computer controlled local anesthetic systems. Then you can use nitrous oxide inhalation sedation to relieve the anxiety and pain, and photobiomodulation therapy with lasers can be suggested. And another thing that you can use to reduce the pain is preemptive analgesia. Non-steroidal anti-inflammatory drugs like ibuprofen, 10 milligram per kilogram, either half an hour or 1 hour before the procedure, or even you can start it 2 days before the procedure as a BD dosage, and this has shown positive results. Then another difficulty is in bonding with in case of composite restorations. In such cases, deproteinization using sodium hypochlorite can be used. What if MIH can be anticipated prior to occurrence? That is, there is another condition in primary dentition which is called as hypomineralized second primary molar, which are demarcated qualitative defects of enamel of systemic origin affecting more than one second primary molars. So here, similar features of MIH are seen, and why this is used as a predictive measure in children which are who are having HSPM are at a high risk of developing MIH because the second primary molar and the first permanent molar has overlapping periods of mineralization. Clinical features and management of HSPM is almost similar to that of MIH. So a correct diagnosis is three-fourth remedy.